Okay, so we'll get started. More problems with Panopto, but we'll see if this is recorded. So next 2 hours we'll be going over neuroradiology, and so today we'll talk a little bit about MRI and CT, how the images are obtained, what are the advantages of an MRI versus a CT, indications for MRI, CT, and then tomorrow morning we'll go over some case studies. We may get into a little bit of case studies today also. So one thing that's really important is that we not rely too much on any neurology patient and just say, well, we'll get a scan. I think we've talked about that before, but we need to take a history, do an exam, make a clinical impression, and we use neuroimaging to give us information that we already know based on the history and the examination. So MRI and CT, unlike the exam, often can tell you the specific cause. So we will see a patient, and we'll do this in some of the case studies, where we'll know, okay, this localizes to the right hemisphere of the brain, and it's sounding like a mass lesion. Well, there's a big differential for that. So the history and exam can help us localize. Maybe we'll get some ideas about the etiology, but then the MRI or the CT frequently can tell us, oh, this looks like a tumor or an abscess or maybe a vascular malformation or something else. So the MRI or CT does give additional very helpful information about etiology. It's really important that you realize these tests, in particular MRI, is very sensitive. In fact, the older that one gets, the more likely you'll find abnormalities on an MRI or a CT scan. So you can't just get the report and you find some abnormalities and say, well, that I've found the cause. They've done lots of studies. If you do MRIs in individuals over the age of, let's say, 60, and you just look at their low back, they're almost always abnormal. You're going to find some disc bulges, some narrowing spaces, and that does not mean that that is necessarily related to the symptoms that the patient is having. So again, the imaging helps to confirm what we're thinking on history or examination. So just as an example, we might do and actually would someone mind just turning the lights down over there a little bit up on front, because I think we'll be able to see a little better. Thank you. So, for example, we might do an MRI scan like this, and we don't need an arrow here. We get a little bright spot right there. So, what's the significance of that? Well, it would depend on a lot of things, the age of the patient, for example. But there's actually a name for this. It's called an unidentified bright object. I'm not making that up. That's actually a term that we use for these little bright spots. And these become more common as you get older. And so really we wouldn't make a lot out of that if it doesn't fit the clinical, what we think is going on clinically. Okay? So we want to avoid neurophobia in this class. So you have some confidence seeing patients, doing your examination, and problem is if you are practicing and you don't know much about neurology, then I see a lot of times where something like this, there's a lot of weight put into this, and a whole trail of workup for something completely unnecessary is pursued. Okay, so when we think of CT, it's helpful to consider whether something is less dense or more dense. So when we say something is least dense, it appears black on a CT. If something is dense, it's white, and we have a spectrum. Okay, so from least dense, we have air, which we'll see is black. on a CT. Okay, water, CSF, is also dark, not quite as dark. And so air and water are least dense. Calcium and blood are most dense, right? So that's very important. Really, there should only be two things that appear white on a CT. One is calcified bone, and the other is hemorrhage. Okay, so if you see something bright on a CT, it's one of those two things. In between is the soft tissue of the brain. Okay, so gray matter, white matter, brainstem, cerebellum, all of that is going to be a kind of an intermediate density. All right, so here's a CT scan. And so obviously we have the calcified skull, and you can always tell when you're looking at a CT because, as we'll see, the MRI looks a lot different. So we got a calcified skull, and we have something else that's calcified right here. And so, yeah, this is the pineal gland, which calcifies normally with age. Okay, so your choices is really, I mean, there's no bone in the middle of the brain, right? So this is either going to be something that's calcified or it's a bleed. And so this is often a helpful landmark. You see that calcified structure in the midline, you know right where you are. Pineal gland, which sits right above the dorsum of the midbrain. Okay, and so this is a section right at that level. The other important thing we've mentioned a few times, but when you're looking at a CT or an MRI scan, it's obviously important that you know what is right and what is left. Okay, so you always have to imagine the patient lying on their back with their feet coming out toward you. Right, so this would be the right, and this would be the left hemisphere. And so we'll go over some of these structures here, just making some general points for now. We used to have a whole hour lecture on the physics of MRI, and we now do that during the neurology clerkship. And so while it's fascinating, we're not going to explain how the images are obtained. We're more going to focus on the anatomy and some practical clinical points for now. But as a concise statement, maybe this is the best we can say it, that the images are obtained by exploiting the magnetic properties of protons in hydrogen atoms. And so it's really fascinating. I enjoy talking about it, but it takes at least 25 minutes to begin to understand how the images are obtained. So we're going to do that during the first week of the third year neurology clerkship. But one thing that is important, you know, when you look at a CT, they all pretty much look the same if it's normal. I mean, skull is bright, air is dark, CSF is dark, and so on. But when you look at an MRI scan, these are obtained in different types of sequences. And so they look very different depending on which sequence you're looking at. Okay, so we'll show you a T1 and a T2. There's also a proton-weighted image. We'll talk about FLAIR and diffusion-weighted images, and something called ABC. And they all have helpful things that they will tell you about what you're looking at in the brain. But it can be a little confusing because you'll see if you're looking at a T1, that looks a lot different than a T2. And just to recognize that by changing things up a little bit, we get different valuable information. So here's a T1 image. A T1 is really helpful just for normal anatomy. Okay, the gray matter looks gray, the white matter looks white. So the CSF here is dark. You get a nice sagittal look here of the cerebellum and the brainstem. We can see the superior and inferior colliculi, the thalamus and hypothalamus, corpus callosum. You know, it's just really nice for normal neuroanatomy. Turns out it's not nearly as sensitive for abnormalities as compared to a T2. Now notice when I go to a T2, everything will look completely different. CSF is now dark, and when we go to a T2 image, the CSF now appears white. Okay, and in a T2, the white matter, here we'll look at the corpus callosum, this now is dark. Okay, the gray matter out here is lighter. And so T2 kind of reverses things up, but for most things, for example, if we're looking for maybe some demyelination out here, like maybe the patient has multiple sclerosis, we're going to be much more likely to find that on a T2 image. So it's more sensitive for abnormalities, So here is a patient that has white matter disease, and that really stands out. You know, the white matter is normally dark, so this is more normal back here, and so we can see lots and lots of white matter pathology here very easily on a T2 image. Okay, FLAIR images, otherwise known as fluid attenuation inverse recovery, are even better than T2, especially for if we're looking for white matter disease, like the patient has multiple sclerosis. And it's more helpful because notice that in a FLAIR, the CSF is now dark. If we go back to the T2, the CSF was bright. So why is that helpful? Well, these lesions here in the white matter, which show up bright or white here, if our CSF is also bright, these can kind of merge in. It can be difficult to tell, is this normal or abnormal? So when we're looking for multiple sclerosis, obtaining FLAIR images is very important, okay? Because you're going to more easily see the white matter changes. Now, if you have a patient that you think has multiple sclerosis and you order an MRI scan and you write, you know, consider multiple sclerosis, you don't need to tell the radiologist, don't forget to do FLAIR and so on. There are protocols for this, and so these will be done automatically. Okay, the other two images we'll talk about are DWI and ADC, diffusion-weighted images and apparent diffusion coefficient images. And these are most helpful when we're dealing with acute ischemia of the brain. So when someone comes into the emergency room with an acute stroke, this is our most sensitive way of detecting the stroke. Usually a CT scan, an acute stroke, is often not very helpful. It doesn't show up for a long time on a CT. And likewise the other images like T1 and T2, it takes some time to show up. But DWI and ADC are great for acute ischemia. And so here is a DWI image. And so ischemia shows up as something bright on DWI. Okay, and these now we can detect these sometimes within minutes of a stroke. We had a patient at the VA just a few weeks ago who just happened to be having an MRI scan for some other reason and had a stroke in the MRI scan, and you could actually see it in real time on DWI. So there it's bright, and the ADC is kind of your helpful confirmation. Now this one's real obvious, but sometimes we'll have a real tiny spot, and we're wondering, boy, is that real or not? So the ADC is kind of your second opinion, and in ADC it's exactly the opposite. Acute ischemia looks dark on ADC images. Okay, so these are the main indications, and again, you don't need to remember this if you're in the emergency room and you think someone has an acute stroke and you send the patient down to radiology. These are done automatically. Okay, so we have CT and MRI scan, and frequently we'll give contrast with both CT and MRI. For CT, it's an iodine-containing contrast. For MRI, it's called gadolinium, and now there are some other options as well. Okay, both contrast agents have potential to damage the kidney. So that's called the contrast nephropathy. It's much, much more common with the contrast given with CT images. Okay, and so there are specific numbers about kidney function that will tell you, is the patient safe to have it or not? All right, so, and I haven't given you those numbers, but just to recognize when we're doing our CT or an MRI scan, we do check the kidney function first and make sure that these are safe. Okay, why do we give CT? Well, why do we give contrast? If you give contrast to someone who just has a normal brain, looks the same. You look at the pre-contrast and the post-contrast images, very little differences. And so contrast is mainly helpful because it increases the sensitivity of your test. You're more likely to find abnormalities if there's anything that breaks down the blood-brain barrier. Anything destructive. So ischemia, a tumor, anything that has a destructive process to surrounding tissue is going to damage the blood-brain barrier. And so things essentially light up when you give contrast. All right, so here's a normal individual. This is a T1 image. Okay, so the CSF is dark, the white matter is white, the gray matter is gray. So this is before contrast, this is after contrast, and you can see a little bit of change, a little bit here in the venous sinus, a few little bright spots around the periphery of the brain, but not much change. This is normal. Very little change post-contrast in normal image. Okay, but here's a CT now, and so we're up near the top of the brain, and you can see there's a dark area right here. And this is what edema looks like on a CT scan. It's fluid, right? The CSF is dark on a CT, and so swelling in the brain like edema also has a dark appearance. But, you know, it's hard to know what that is. Okay, now we give contrast, and you see this spot light up right here. So this is a metastatic, I think, lung that had metastasized to the brain, and metastatic lesions often have a dramatic amount of edema around it, but giving the contrast allows us to see not just that there's a vague area of abnormality here, but now we can actually see the tumor. Okay, so contrast is really helpful, increases sensitivity of the test. So there are specific indications, and this is really important. You work in the emergency room, or seeing a patient there, and it's, you know, your choice. Do we want a CT or do we want an MRI scan? CT images are very fast. Okay, we can just get the patient down to the radiology department, get the images, get the information right away. So that's an advantage. It takes longer to get an MRI scan. And so for head trauma in particular, you know, someone's in a car accident, maybe they're confused, you're not waking up, that would be a time to get a CT scan. Is there a bleed? Do we have a skull fracture? We get that information quickly. The basic rule of thumb is if your top differential is a bleed in the brain, acute hemorrhage, always do a CT scan. CT is very sensitive for acute hemorrhage. And again, that's a neurologic emergency. You know, this patient needs brain surgery. You know, these are decisions that need to be made quickly, and so a CT, you can get that information. CT is also excellent for bone imaging. I didn't put some pictures in here of this, but we can do wonderful like facial reconstruction from a CT in 3 dimensions. You can just sit it in your office, you can spin it around, and you can tilt it different directions and look for fractures or anything like that. So if we're looking for a skull fracture or something, CT would be very useful. MRI is not very good at looking at bone. Okay, but there are distinct disadvantages to CT. It really does quite a poor job looking at the posterior fossa, meaning the brainstem or the cerebellum. All right, so for example, if you think your patient has lateral medullary syndrome, CT has no chance of detecting that. It's just too small of an area, and we'll see when we look at CT images through the posterior fossa, we get all these lines of artifact because of all of the bone around the posterior fossa. Okay, so it's not very sensitive for something in the brainstem or cerebellum, with the exception that if you think it's a bleed, like you think the patient has a bleed in the brainstem or the cerebellum, then you would still do a CT. But for most other things, CT is not going to be that helpful. Now, we are just starting to get sagittal images on CT, but they're not nearly as good as MRI scan, where we can do a whole sagittal section from right to left hemisphere of midline. So sagittal images, which are sometimes helpful, are much better MRI than CT. Okay, overall, CT is much, much less sensitive. Okay, so we're much more likely to find the abnormality on an MRI scan. So for neurologists, I would say when we get a scan, it's almost always an MRI scan. We'd rather get the better scan, with the exception of head trauma, acute hemorrhage, a few indications where CT are more helpful. So MRI advantage is kind of the opposite of CT. If you're looking for something in the posterior fossa, you need to do an MRI scan. Much, much more sensitive for just about anything you'd want to look for. And it's always a pity, you know, when a patient has a CT scan and then we end up seeing them and, well, they really needed an MRI scan. So they get 2 studies right? Better just to do one, just do the best study to start with. MRI does take longer, okay, and you need to have the patient lying very still during an MRI scan. So, you know, if you've got a alcoholic patient in the emergency room who's kind of flailing around, you're not going to get very good images. That patient's not going to be able to lie still for the 30, 40 minutes it takes to get an MRI scan. So you need to have a patient who can cooperate and lie still for a period of time. And again, that patient, if they're moving around, if they're claustrophobic, you know, you're going to get artifact and not going to get very good images. Yes?
Is there a difference in quality between the open MRIs and the closed MRIs?
Yeah, so that's a good question about open MRI scans. Not much. Is there much of a difference between closed MRIs and open MRIs? There is a little bit of difference. So our closed MRIs, we can get a bit more detail, but I would say it's not that significant. So yeah, if you do have someone who's claustrophobic, an open MRI is a really good option. Yeah, and oftentimes, if someone is claustrophobic, we'll give them a little sedation just to help them make it through the study. All right, so really important here that we can't do MRI scan in certain indications. The biggest one is pacemaker. You know, in a recent development, there are some MRI scans that are compatible with pacemakers, but these are not available in most facilities. But so it's really important then, if you're ordering an MRI scan, you need to ask the patient several questions. The first one, do you have a pacemaker? Okay. And there are certain aneurysm clips or metal implants. So the patient has shrapnel. We just saw a patient a few weeks ago, and MRI was really important. I mean, it was just critical. And he's had a piece of metal since, you know, for 30, 40 years, right under the eye. And so the radiologist was saying, boy, if that moves, you know, this could be devastating. So we should have plastic surgery come and take the little metal piece out, and then he could have the MRI scan. So we need to ask these questions before we send the patient down to the MRI scanner. And the radiology technicians will also ask the same questions again. So there's kind of a double screening here, but it's bad form to send someone down for an MRI who has a pacemaker. Remember, CT is great for looking at the bone reconstruction, putting it in 3 dimensions. MRI is not so good if we're looking for something in the skull. And claustrophobia, you know, very common. I think more so where I work at the VA, you've got veterans who have PTSD and you put them into an enclosed space. And so claustrophobia is a big issue. We'll often give a little Valium or Ativan or something to relax the patient, but sometimes they just can't go through with it. And then an open MRI is a good option from there. Okay, something we won't talk about in detail in these lectures, but I just want you to have an idea that we can do a CT or an MRI scan and have the scanner focus just on the blood vessels. Okay, and we get a beautiful look at cerebral vasculature here. Here's a CT angiogram, okay, where we can see the internal carotid artery and the middle cerebral artery, the anterior cerebral artery. You know, we look here at the posterior circulation, the basilar artery, and the vertebrals. Okay, so that's helpful, again, especially in stroke, to look at the cerebral vasculature. And here's an MR angiogram, okay, which likewise, just everything we've been talking about. Here's internal carotid, MCA, ACA, basilar artery, and the posterior cerebral arteries coming back here. So we can look for an acute stenosis or any focal problem of the vasculature. We can do this down into the neck, so we can look at the carotid arteries as well. And if we want to look at the veins, we can do an MR venogram. Okay, and so here is the superior sagittal sinus. And so much nicer now that, you know, conventional angiogram where you're having to put dye in has some risk, really. So to be able to do these tests non-invasively is fantastic. Okay, so I want to go through on a T2 sequence and just show you some normal anatomy. And I was thinking about it here last week and decided, I mean, we're coming up to the very end here of your first year of medical school, and So I think for the next little bit, just relax. We're not going to ask any questions on identifying structures. So this will be just kind of, I didn't want to dump all of this on you here right at the end. So we're just going to go over a little bit normal. Okay. Now I will say I did spend the time labeling all of these nicely. So, and actually I didn't do all of this, but by the blue stars. Anyway, so we'll have enough time, I think, in the second year to kind of emphasize this. But let's start down in the posterior fossa. So get a nice look here at the medulla and the cerebellum. And remember the connection between the medulla and the cerebellum here. These would be the inferior cerebellar peduncles right here. And here are the medullary pyramids. Remember the medullary pyramids are on the ventral surface. So our cortical spinal tract is right here. Nice look at the cerebellum, then the cerebellar tonsils. Okay, now flowing blood on an MRI always looks dark. So that's kind of a helpful thing. And so what we're looking at here, this is the basilar artery. And we can see a little bit of the vertebral artery on this side. And so what we're seeing here is the vertebral artery on the right kind of merging into the basilar artery. So when we're looking at vasculature on an MRI scan, we need to look up and down a few levels to kind of in our mind put together the three dimensions of it. Okay, but this is the vertebral artery becoming the basilar artery here. Now there's a lot we can identify up here, but this is neuroscience. Right, so the nasal septum and the maxillary sinus and the pterygoid muscles, that's all interesting, but not something here we're going to do in this course. I will say again, flowing blood looks dark, and so what we're looking at here is the internal carotid artery. Okay, so there are all of the labeled structures. Okay, as we go up, we're into the pons now. And so remember, the pons has a massive connection with the cerebellum. So this is the middle cerebellar peduncle right here. Okay, cerebellum. Here's the fourth ventricle. Remember, CSF looks bright on T2. Okay, and then the basilar artery again is sitting right there on the pons. This is actually the inner ear right here. You can see the cochlea, the semicircular canals. And so cranial nerve 8 is going right out into the inner ear in that area. Okay, and what we're looking at here is just the undersurface of the temporal lobe as we move up. Okay, and here are the internal carotid arteries again. All right, more of the same, basilar artery, pons, cerebellum, temporal lobe, internal carotid arteries. And what we're seeing back here is, remember the occipital lobe sits right on top of the cerebellum. Okay, so we go higher up into the cerebellum, we can see a little bit of the occipital lobe there. Okay, so the cerebellum kind of has this appearance. Okay, so this is all cerebellum, and this is now the occipital lobe back here. Okay, we have a venous sinus right back here. Temporal lobe, basilar artery, internal carotid arteries. Okay, now the fourth ventricle, here this is getting smaller, and so this is becoming the cerebral aqueduct right here. This will have a more classic appearance when we get up into the midbrain. And you can actually make out lots. You can see extraocular muscles and all kinds of things looking at the orbit as well. Okay, so now we're in the lower midbrain. We can see the cerebral peduncles. Here's the cerebral aqueduct, temporal lobes. Okay, and we can actually see the perihippocampal gyrus out in this location over here. Okay, parietal lobe and then the occipital lobe back here. Now notice here, if we follow the optic nerve back, there's the optic chiasm, and we can follow the optic tract. Okay, so we can actually see nicely here the optic nerve, chiasm, and tract. Now this has more of a classic appearance of the midbrain with the Mickey Mouse ears. So these are the cerebral peduncles. cerebral aqueduct. Okay, remember flowing blood looks dark, so what we're looking at here is the middle cerebral artery, which is tortuous, right? It's kind of going up and down as it moves out through the Sylvian fissure, and so on a single section, that's why we see it here, then it disappears because it looped up or down, and now it appears here again. Okay, so everything you're looking at out here, these are little loops of the middle cerebral artery. Okay, again, parahippocampal gyrus out here, and these are the optic radiations. Then going back to the occipital lobe. Okay, and now we can see the midbrain, not just the cerebral peduncles, but if you can see there's a little lighter white area there, that's the substantia nigra. The red nucleus. Okay, why is the red nucleus dark? Well, since other neurons here appear white, the decussation of the superior cerebellar peduncle is also right in that area. That's a pathway. It's going to look dark on an MRI scan. So it's kind of we're looking at a couple of different things here. Again, there's the cerebral aqueduct, and we can see the superior colliculi right back here. Okay, just a little bit of the top of the vermis of the cerebellum, but most of this back here then is occipital lobe, and we can follow the pathways, the optic radiations on their way back here to the occipital lobe. Okay, this is the first time we've seen the frontal lobe. This is the straight gyrus, or the gyrus rectus, which is kind of the lowest portion here of the frontal lobe. Okay, and notice what is sitting right next to the cerebral peduncle here. It's this part of the temporal lobe, so this is the uncus. Okay, so remember the third nerve is exiting right here. So we've talked about uncal herniation and how that can compress the third nerve. And next year we'll talk about how that can also compress the cerebral peduncle. Now we've got two rounded structures right here, and these are the mammillary bodies. Okay, so the hypothalamus is this whole area right around it. Okay, and again, middle cerebral artery here going out on both sides, and a little bit of the anterior cerebral artery right here. And there they are labeled. All right, as we get above the midbrain now, we've got a pathway here that is crossing over. So what do you think that pathway is from January? Yeah, the anterior commissure. It's the only pathway that crosses over like this. Remember, it's interconnecting temporal lobe structures, especially the hippocampus. All right, so this is the Sylvian fissure out here. So remember, CSF looks bright on an MRI, so this is also bright. So we're looking at the space here in the Sylvian fissure. This is all Sylvian fissure. So the little dark areas here is the middle cerebral artery, because remember that is out in the Sylvian fissure. Okay, here's the gyrus rectus. We can still see the optic radiations going back here to the occipital lobe. And now we get a good look at the internal capsule. Okay, so we can see the landmarks here of the internal capsule. Remember, medial is the caudate and the thalamus. Lateral is the putamen. So we have the anterior limb, the genu, and the posterior limb right here. We now begin to see parts of the ventricular system. Remember, the caudate nucleus bulges into the lateral ventricle. So the little white that we're seeing right here is CSF. That's the lateral ventricle. Okay, and we can see more of the lateral ventricles back here, the trigone, and going back to the occipital horn. Now we get a nice look here at the corpus callosum. Okay, this would be the genu of the corpus callosum, and then the splenium of the corpus callosum back here. Okay, and out here in the Sylvian fissure, you get all kinds of little, you can see these looping blood vessels. Here's one little loop right there. These are blood vessels. So everything we're seeing here that is dark is still middle cerebral artery. And remember, it extensively branches out to supply the lateral hemisphere. The anterior cerebral artery, we just see a little bit right there and there. The little dark areas here that will supply the midline portion of the brain. All right, so what's a gyrus that sits right on top of the genu of the corpus callosum? That's the cingulate gyrus, right there. Okay, and as we go up, we can mainly just make out lateral ventricles, nice look at white matter, caudate nucleus, and a nice distinction here between gray matter and white matter out on the surface. Okay, and then we just move up to the top of the brain. Now, CT, you'll notice just, from a bird's eye view, the detail is not nearly as good on CT, right? Things just kind of look a little bit fuzzy. If we're looking for, again, that's why I say a sensitive test. MRI is much more sensitive to detect abnormalities. So if we start down at the base of the brain, first of all, just notice on a CT, and again, you can tell it's a CT because of all the calcified skull. Remember, what looks dark on a CT is air. Okay, and so what we're looking out here is we have the mastoid air cells out here, and so frontal sinuses. So all of the dark areas represents air. And notice back here the posterior fossa. So here's the medulla, here's the cerebellum, and you see all of these lines of artifact. Also, these run through the temporal lobe. That makes it very difficult to detect abnormalities there. So the bony skull, all of the skull in that area, creates these lines of artifact. They're called Hounsfield lines of artifact. And you'd never be able to pick up a lateral medullary syndrome. What's normal, and we've got a mixture of signal here in the medulla. So that's why, again, CT is not that sensitive if we're looking for something posterior fossa, other than a bleed. Okay, as we move up on a CT, well, we can see the basilar artery right there, sitting on the pons. Okay, so these are the middle cerebellar peduncles, again, connecting the pons with the cerebellum. Temporal lobe, but still lots of lines of artifact here, and now the undersurface of the frontal lobe. Okay, and again, we got a good look at the mastoid air cells here. Okay, as we move up, we can still see the basilar artery. Okay, now sitting on the midbrain, kind of the junction between the midbrain and the pons. So here's the fourth ventricle. Okay, and the cerebellum, and we're getting a little bit into the occipital lobe back here. Temporal lobe with Sylvian fissures. So remember, fluid on a CT looks dark. So the space here in the Sylvian fissure is going to have a dark appearance. Okay, and then the frontal lobe up here. All right, and this is actually a helpful space right here, kind of a smiley face right there. And it's a helpful space because it tells us what is around it. This is called the quadrigeminal space. Okay, and when we see that, we know that's the space right around the superior colliculi of the midbrain. So we know these are the superior colliculi then once we found that space. So this is actually the midbrain that we're looking at right here. It kind of gets mushed in with everything else. Okay, but this is the midbrain, so probably the red nuclei are here, the cerebral peduncle out in this location, but again, not nearly the detail that we can look at it with an MRI scan. Okay, so this is still the cerebellum, and see the occipital lobe here. A midline space then is the third ventricle, right here, and we see the lateral ventricles out here. Okay, and we do get a decent look here at the internal capsule on a CT. So here's the anterior limb, the genu, the posterior limb. There's the caudate nucleus bulging into the lateral ventricle. And here's the thalamus, which remember is medial to the posterior limb. And then the putamen and probably a little bit of the globus pallidus here in the medial portion are the lentiform nuclei that are just lateral to the internal capsule. All right, third ventricle, again that quadrigeminal space, so we're still looking here at probably the superior colliculi, upper portion of the midbrain. There's the vermis of the cerebellum and the occipital lobe, the optic radiations back here. Okay, more of the same here. Again, nice look at the internal capsule, caudate, putamen. This is the pineal gland right here. So in this case, it didn't calcify in this individual, but so we're right above the midbrain. And nice look at the lateral ventricles here. And then as we move out, just like on the MRI scan, once we get above the internal capsule, we're mainly looking at lateral ventricles and a nice distinction here between the white matter and the gray matter. Here we can see the splenium of the corpus callosum. And the optic radiations here. Here's the venous sinus right back there. So none of that will be asked on this test. All right? That was just a quick run through. But it would be really important that you know everything else that we just said before. What are the advantages and disadvantages, CT, MRI scan? What are the indications for both? Make sure you know that. All right, so let's go through a case or two here to get started. So we have a 45-year-old man involved in a motor vehicle accident, struck his head on the windshield and briefly lost consciousness at the scene of the accident. He had a mild headache, but did not go to the emergency room. About 6 hours later, he felt that his headache worsened, and he noted numbness and clumsiness of the right hand and leg. His wife drove him to the emergency room when he didn't seem to understand what she was saying. When he tried to speak, it didn't make sense. Okay, so remember, we always want to localize first. Okay, so as a very big picture, where are you concerned a lesion might be in this case? Yeah, left hemisphere. Let's just get the hemisphere right, okay? Now, what would be nice if we knew, and maybe we should have in here, is he right or left-handed, right? If we could ask his wife if he's right-handed, then that would more firmly put the language-dominant hemisphere on the left. But he's got some clumsiness of the right hand and leg. So we not only have what sounds like a language problem, but we have some contralateral weakness. So we're concerned about something here going on in the left hemisphere. So on exam, he was sleepy and somewhat difficult to arouse. Now this is from a lecture in the second year course, but in neurology, when especially someone's had head trauma, when they're sleepy and difficult to arouse, that's very meaningful. That is a symptom of increased intracranial pressure. Okay, so it could be other things, but that would be one of the top symptoms of increased pressure in the brain. The patient can't stay awake. Okay, and then he said, and I had a patient say this to me once, and I wrote it down, I thought it was a great example. I was in a crawl accelerator, and that isn't the only way it goes, you know. Okay, what does that suggest to you? So the first question, anytime I've got a language problem, is it fluent or non-fluent? It's fluent. So Broca's area seems to be working, right? This is a fluent aphasia. So this is sounding like a Wernicke's aphasia. What do you call the words like crawl accelerator? That's a paraphasic error, which is just a classic feature of a Wernicke's aphasia. Okay, and so now we're getting more specific. We're not just saying, okay, it sounds like left hemisphere, but it sounds more, posterior left hemisphere, involving Wernicke's area. He can't follow commands. Okay, why do you think he can't follow commands? He's got a Wernicke's aphasia. He doesn't understand what you're saying, right? That's the receptive language cortex. And he appears to have right arm and leg weakness, which would go along with a left hemisphere lesion. So this must be at least far enough anterior to affect the motor cortex. And he has a right extensor plantar response, is upgoing. Does that surprise you? No? If the lesion's in the brain, we're looking for upper motor neuron findings, right? So to have a Babinski on the right is more confirmation. Okay, so localized lesion, we've said left hemisphere. Okay, and left hemisphere involving Wernicke's area, and left hemisphere involving the motor cortex. Okay, so what are some possibilities? Don't look forward to the scan yet, but you're in the emergency room, and what are some things that this could be? Could be a bleed, right? What type of bleed? Could be a subdural, could be an epidural, right? So those are good choices. Anything else we want to have kind of in our differential? An MCA stroke? Could it be an MCA stroke? Sure, that could cause an aphasia. Now, usually trauma doesn't bring on a stroke, so there would be, you could dissect your carotid artery from trauma, but typically trauma is going to put us more in a bleeding, category. But it's something we should have on our list of differential. All right, so in this setting, what scan do you want to get? CT, our top differential is a bleed. Right? We need something fast. We're looking for a hemorrhage, so we need a CT scan. All right, so here's the CT. So tell me, what do you see there? I hear a mixture of subdural and epidural. Anyone want to argue for one or the other? Yes?
I'm guessing subdural because it looks like it's underneath the, I'm forgetting that word, underneath whatever. And it's like really big and crescent shaped.
Okay. Can be hard to tell, but in general, if you see something wedging into the brain, it's an epidural. Subdural hematomas tend to layer out along the entire surface of the brain. They don't wedge into the brain like that. So this is an epidural hematoma. And really in a young individual, epidural hematoma is more likely. As you get older, the dura becomes more adherent to the skull. And so we don't see epidural hematomas in the elderly that much. Children with head trauma, young adults with head trauma, epidural is more likely. Okay, and notice it's bright. So acute hemorrhage looks bright on a CT. So this is an acute hemorrhage, and it's in the right location, right? Because this is Wernicke's area, right back in here. Okay, and we can see there's some mass effect, so we wouldn't be surprised that this also involves some of the motor cortex. Epidural hematomas are highly associated with skull fracture, which we can't see on this image, but we wouldn't be surprised to see a little fracture of the skull there. Okay, and very important, epidurals are arterial blood, usually laceration of the middle meningeal artery. So we just described the findings, pathophysiology of skull fracture, laceration of the middle meningeal artery, arterial blood wedging into the brain. Okay, and if we contrast, this is what a subdural looks like. Okay, again, notice it's layering out along the entire surface of the brain. Subdural hematomas are much more likely in the elderly, and this is a venous hemorrhage, not arterial. Subdural hematomas, it's shearing and bridging veins. Okay, the other thing we could say about this is all dark. And so what that tells us is this has been there for a while. So acute blood looks bright on a CT, but after days and weeks, the brightness turns into just a dark fluid-filled, like the CSF kind of intensity. Here's a subdural hematoma that is acute. Most of it is. This tells us it's been there a little while because there's a dark component. And look at the mass effect. Here we see the right lateral ventricle, but we don't see the left lateral ventricle. That's because it's obliterated by the pressure mass effect in that location. Okay, so we've diagnosed the patient. What do you think is indicated in terms of treatment? Yeah, we need to call a neurosurgeon, right? So we need to evacuate the hematoma, and so they can create a hole in the skull and evacuate that. And this is really an emergent thing. There's some individuals that have epidural hematomas. There's no atrophy of the brain when you're young, so there's nowhere for that pressure to go. It's amazing the elderly can often accommodate a large bleed quite well just because of some atrophy and there's some space. But this patient needs urgent neurosurgical intervention. Okay, so let's stop there and we'll do the last of our cases tomorrow.